Everyone. My name is Michael Ghannam from the University of Michigan. I'm very grateful for the opportunity to talk to you today. My presentation will be on catheter ablation of parahisian premature ventricular complexes in patients with and without cardiac scar. I have no relevant financial disclosures. To begin, we'll talk briefly about PVC ablation indications and outcomes and review the unique anatomy of the parahisian region, which makes these cases so challenging. We'll talk a bit about why LGE-CMR can be useful for PVC ablation procedures. And finally, we'll review our center's experience with parahisian PVC ablations and the impact that LGE-CMR scar may have on these procedures. PVC ablation is one of the more common procedures we perform in the lab, typically for a number of reasons outlined in our expert consensus guidelines, including alleviation of PVC symptoms, prevention or treatment of PVC-related cardiomyopathy, elimination of focal triggers for ventricular fibrillation, improvement of physiologic pacing, and this can be considered when antiarrhythmic drugs are either ineffective, not tolerated, or not preferred. As a whole, PVC ablation is an effective therapy. This multi-center study from a few years ago demonstrated an overall success rate of 85%, and a modest rate of major complications at 2.4%. However, the success of these procedures are highly dependent on the arrhythmia site of origin. So for example, RV outflow tract PVC has success rates approaching greater than 90%, while more challenging cases such as papillary muscle or epicardial origins have success rates closer to 60 or 70%. While parahisian PVCs were not specifically examined in the previously mentioned study, there are some case series out there. Generally, we define these as PVCs with a site of origin within 10 millimeters of any near-field His signal. They're not uncommon, representing about 3 to 9% of idiopathic PVCs. There are some characteristic EKG findings that can be used to identify these arrhythmias pre-procedurally. However, there's a deal of variability as these can be located in different cardiac chambers and inferiorly and superiorly to the bundle of His. And the challenge of these ablations, of course, stems from the proximity. Understanding the anatomy of the parahisian region is critical, not only for PVC ablation, but this region also comes into play for SVT ablation, parahisian atrial tachycardias, and septal accessory pathways. The figure on the left shows the midline structures of the heart from an RAO view. Recall that the AV node is here at the apex of the triangle of Koch, and this transitions to the penetrating portion of the His bundle here at the membranous septum. From there, the bundle of His runs about 20 millimeters or so before dividing into the right and left bundles at the ventricular crest. So if we define the parahisian area as this yellow dashed circle, you can see that we can sample the ventricular portion of the parahisian region, not only from the right and left ventricle, but atrially here at the region of the slow pathway, as well as from the right coronary cusp. The figure on the right shows the midline structures from the LAO view with the membranous septum transilluminated, and we see that the bundle of His is now divided and continues on as the left bundle branch, again showing this close relationship to this region and the aortic cusps. Patients in our series all underwent pre-procedure late gadolinium enhanced cardiac MRI. The utility of pre-procedure imaging for VT ablations has been shown by multiple groups, but we've found it provides a lot of insight for planning PVC ablations as well. From our prior work, we've shown that when we scan consecutive patients with normal EF, no ischemia, undergoing ablation, who otherwise would have been deemed to have idiopathic PVCs, that we find notable cardiac scar in approximately 25% of patients. Also, this scar provides information on the arrhythmia site of origin 90% of the time, and the presence of intramural scar is strongly associated with the presence of an intramural PVC site of origin. And a couple of examples of that intramural scarring is shown in the images on the left. This is notable as really it's our best way to determine pre-procedurally if there will be an intramural PVC. There are no well-validated EKG or demographic parameters. This also has important considerations for risk stratification. Even among patients with normal or near normal ejection fractions, the presence of LGE CMR scar predicts not only VT inducibility, but also clinical VT events and ICD therapies in the future. We put together a series of 48 patients with parahisian PVCs undergoing ablation, all of whom had pre-procedural imaging. We found that LGE scar was present in nearly 70% of patients. There were little demographic differences between those with or without scar, but scar was more common in male patients. In line with our prior findings, nearly half the patients with scar had normal ejection fractions. Patients had predominantly intramural scar located within the basal midseptum in the parahisian region. Shown here are the results of the mapping and ablation portion of the procedure. And a key finding in our series is that multi-chamber mapping and ablation is critical to safely and successfully targeting these arrhythmias. Now, while a pre-specified mapping and ablation approach was not used, we generally began by first mapping in the right ventricle and moving to the cusps in the left ventricle if adequate target sites could not be found or if ablation resulted in conduction abnormalities. As you can see, all patients underwent RV mapping, 48% LV, 44% cusp. And ultimately, ablation was performed in all of the areas that we reviewed in the anatomy slides, the RV, LV, cusps, and interestingly, pretty frequently at the area of the slow pathway in 10% of patients. So in total, 44% of patients required ablation at multiple sites. Now, while targeting these arrhythmias, it's critical to be vigilant for conduction disturbances. We saw junctional tachycardia with RF in 44% of cases and transient heart block that resolved with cessation of ablation in 20% of patients. Ultimately, the site of origin was deemed to be originating in the right ventricle in 38% of people, left ventricle 10%, and primarily these were intramural arrhythmias corresponding to that area of intramural LGE scar. Here is an example of ablation of a parahisian PVC with an intramural origin. Panels A and B depict the patient's pre-procedure cardiac MRI, and highlighted with these yellow arrows are the intramural scarring seen both in the short and long axis views. We often use the InHeart software, which many of you may be familiar with, to export this scar data and overlay it right onto our electroanatomic maps, which is shown here. This is the left ventricle, right ventricle, and the basal intramural scarring shown here in green. The sites of earliest activation in the left and right ventricle are shown here in panel C and D. And you can see that both sites display far field electrograms that are presystolic, both about 40 milliseconds, with poor pace maps at those early sites. And during this procedure, ablation was first performed in the left ventricle, which led to only a partial suppression of the PVC, and with ablation at the right ventricle at these early sites, the PVC was ultimately eliminated. Here's another example of the importance of multi-chamber mapping and ablation. This patient too had intramural scar not depicted. Here is an activation map on the right ventricle and the His bundle tagged with the yellow markers here. And right at this site of earliest activation, we see presystolic activity on the local EGMs, quite sharp, but in close proximity to the His cloud. Ablation here resulted in transient heart block, which fortunately recovered when we came off. Mapping was then performed within the right coronary cusps. And here you can see a very far field signal with similar timing and a nice QS wave on the unipolar signal there. Now, even though we were unable to achieve capture with pacing at this site, we were able to eliminate the PVC with long duration ablation lesions. And again, this is also consistent with a intramural site for this parahisian PVC. One more example showing elimination of a parahisian PVC from the cusp. Again, our electroanatomic map is shown with the overlay of the intramural scar here in yellow. And with left ventricular mapping, we see this clear breakout site in the left ventricular endocardium with a nice sharp presystolic EGM and perhaps a blunted far field component. Despite this being quite presystolic, ablation here had no effect on the PVC. So the catheter was withdrawn again to the cusp, and again we see these far field blunted signals with a similar activation time, and ablation here was actually successful, despite being quite remote from the LV endocardial activation site. And this is a good example that reminds us then that while dealing with these intramural PVCs, the true site of origin is unclear unless we have mapping catheters or wires within the perforating branches of the coronary venous system to sample the intramural space directly. All we see with endocardial mapping are the breakout sites. And with this phenomenon of preferential conduction through the myocardial layers, particularly in the presence of intramural scar, those endocardial exit sites may be quite remote, or in fact in a different chamber altogether than the ultimate successful site. Example this time showing ablation of a parahisian PVC at the area of the slow pathway. So again, our patient had a pre-procedure cardiac MRI demonstrating a basal intramural scar. We're then able to import that to our electroanatomic map of the right ventricle here. And we began this case by mapping within the right ventricle here at the region circled in yellow in very close proximity to our His location. And at this right ventricular site, pace maps were close but not matching, but there was a nice sharp presystolic signal that was quite attractive. However, with ablation here, we saw the PVC change morphology without a decrease in the frequency. Further mapping was performed at the area of the slow pathway here in red, inferior and posterior to our His bundle. And here we had better pace map and slightly earlier timing. And ablation here eliminated this PVC. So what we've done is, with our RV ablation, is alter the exit site, resulting in the altered morphology, but the PVC site of origin was better targeted here at the area of the slow pathway. So examining this together, we find that among patients with parahisian PVCs, those with cardiac scar were more likely to have intramural PVCs at 64 versus 27%. They were more likely to have more complex procedures requiring ablation in multiple chambers and greater ablation times. And additionally, all patients in this series who did have inducible VTs were found to have cardiac scar, and those VTs localized to the region of the cardiac scar. Looking at our outcomes, acute procedural success, meaning complete elimination of the parahisian PVC, was attained in 69% of patients, and partial success, meaning a reduction in the burden but not elimination of the parahisian PVC, was obtained in 16% of patients, and in 15% we had procedural failure, all due to new or impending conduction system damage. Overall, the cohort's burden of PVCs were reduced from 21% to 6% on follow-up Holter monitoring. In terms of safety events, one patient developed new complete heart block. However, that was in a patient with an existing CRTD device, and we felt that elimination of the arrhythmia took precedence. 10% of patients developed a new bundle branch block, which did not require treatment, and there were no other major procedural adverse events. A few limitations. We did not utilize multipolar mapping catheters routinely in this study. That may help further refine the appropriate ablation targets compared to a roving catheter. In terms of future techniques, there's been interest in refining pulse field ablation in some interesting ways that may suit itself to parahisian ablation. There are some preclinical data to suggest that certain PFA parameters could lead to sparing of the specialized conduction tissue over the myocardium, and we're seeing some attempts at using PFA in a reversible fashion. Very, very far from any clinical applications, but an area of active research nonetheless. In this series, we can conclude that parahisian PVCs are often associated with intramural scarring and the need to perform multi-chamber mapping and ablation to target the site of origin, which is often intramurally located. That the presence of scar has implications for ablation strategies and the risk of VT recurrence, and was often detected in patients with preserved ejection fraction. And lastly, radiofrequency ablation complemented by cryoablation is safe and had a midterm success rate of about 70% for parahisian arrhythmias. And with that, I will conclude. I wish to again thank the conference organizers for allowing me to share our work, and thank you all for your attention.